Hello and good evening to everyone. And today we have the incredible pleasure of speaking with Professor Daniel Goldstein. And just to give you a little bit of understanding, he was #1 on LinkedIn as Frontline Healthcare this year because of the work he's been doing with COVID-19. Incredible opportunity. Here we are. Hi, Danny. How are you doing?
Hey, Philip, how are you?
Excellent, excellent. Great to have you here with us. And I think I want to do this as an example to show people just who you are, who they've been interacting with for this long time. So yes, so we've got some time to chat with you now, Danny. You are quite fascinating, largely because, and I'll deal with this one up front. You are a surgeon, okay? Surgeons are not interested in anything outside of surgery. Am I right or am I right?
I think that's a little bit of an overstatement, but most surgeons don't have these sort of inclinations.
Absolutely. I'm absolutely telling you that. I see surgeons all the time, and I would very rarely get any one of them talking about COVID-19. So it's incredible what you have done. So tell us at the start, what really actually got you interested in this?
So as you all know, New York was the epicenter of the world when COVID struck. And very quickly in early March, it was obvious what was going to happen in New York City, that essentially we will all have to be redeployed. At mid-March, end of March, every single hospital bed in New York City was a COVID bed. I'm not talking about ICU beds. I'm talking about every hospital bed in New York City. And I found myself redeployed to a retrofitted ICU. It was a pediatric intensive care unit, actually. Not a pediatric chemotherapy unit.
Yes.
Which was in 72 hours converted into a COVID ICU. And our team got sort of redeployed and asked to man this unit. So I became, and again, all elective surgery was done. There was no surgery. There was nothing except, people are dying, sort of emergency surgery. So most of our time was spent in this unit, and we went on to a shift modality, 12-hour shifts. So I'll find myself doing 3-4 shifts a week and having a lot of extra time in my hand.
I see.
And, my family, we got separated for, fear of transmission. So I was basically alone with a lot of time in my hand. And I was really fascinated from the outset on what this virus could do to the people.
Yes. Yeah.
And, not having the surgical tools, my surgical tools and skills were inutile. And I found myself gravitating towards reading about this virus. And given the frustration we all had at the bedside watching these young and old people die, I said, well, let me try to learn as much as I can about this, and maybe share this with the community at large. And that's sort of how the journey began.
That's how it started. That's incredible. That's incredible. And so we're going to come back to COVID in a little bit, but tell me a little bit about you. That name Goldstein, where are the roots from with that?
The roots go back to Romania. My family escaped just before the Second World War finished, and they got on a boat that ended up in Venezuela. And my father went to medical school in Venezuela, then did his training in the United States as a physician, a hematologist, not a surgeon. So smart doctor, opposed to myself. And met my mother in Boston. And then, funny enough, life's a circle. He was doing his fellowship at Montefiore, where I'm at right now. And I was born in Montefiore.
Wow.
And then 6 months later, he returned to Venezuela to start his practice and sort of join his father, my grandfather, who was also a physician.
Wow. So it's a family of physicians, generations. Yes.
It's a family event. So I was born in the Bronx, and I grew up in Venezuela, and I was there through high school. And then my mom was American. My father trained in the American system. So they thought I'd be better off with an American education. So they sent me out solo to the United States. and here I am.
Wow, wow. So you were about 16 when you came, weren't you?
Just 17.
Just 17. And what was your English like at the time?
Well, since my mother was American, we spoke, colloquial English at home.
Yes.
I never read a book or wrote a paper in English. So the idea of going directly to college was not terribly enticing to them. I didn't know any better. And they thought that a year in prep school would be a sort of a good segue, a good intermission touch point before heading to college.
Wow. And was that when you got your first interaction as being a poet?
Not quite. My first interaction with the English language was the second day I arrived at prep school, where you had to wear a tie and a jacket every day. And Mr. Snores or Shorts or something like that asked us to write a 2-page paper on a page on Othello. So you might imagine, here's a little Jewish boy from Venezuela who barely speaks English, has to read Othello and write a paper. So that was sort of a monumental task for me. Interestingly, they roomed me with a English major, and I think they might have done that on purpose. I'm not sure.
Mm-hmm.
But I was influenced by him in retrospect, because he had this love of seeing what words go together to make a pretty sound. He's actually became a writer. He's actually a writer now, I think, in New Orleans or somewhere in the South. But perhaps that was my first influence.
And it's because I said it because so much of what you do is almost in a poetic way, and it just seems as though it oozes out of you in everything that you type and you write. So this is why I wondered about it.
Yeah, I can't tell you how that came about necessarily. I think if you go back in the history of my posts, most of them were scientific at first.
Yes.
I was consuming vast amounts of data, mostly from Google Scholar and medRxiv, the preprint server.
Mm-hmm.
What I would do is I'd take the post and sort of bullet it and make it very digestible for people with little understanding. Some of the stuff obviously you have to have some scientific background. So that's where I started. I didn't start poetically or lyrically, so to speak. And sort of I became, I guess, as I got more moved about what was happening in the field and seeing people die in awful ways, lonely without their families.
Yeah.
Became more emotive, if you will, and that's started to pour out in my posts.
So sometimes one of the things that happens in clinical work is something touches you, and in that period of time with the COVID, when you were dealing with the patients and the families, was there any moment that really touched you, that triggered maybe some of the thinking that you've got?
I can't tell you it was a given moment, but it's the feeling of being in an ICU, and so the heaviness that suffused the air in the ICU, the frustration we all had that we seemingly couldn't do anything. We were watching 2 to 3 people die in our 16-unit bed every night, old and young. I remember we had a 32-year-old who just got married 2 weeks ago. He died. I remember a 72-year-old Greek man whose daughter would call us every day, so that we can pipe the voice of his grandson into a earphone.
Yes.
And basically, he died listening to his grandson speak to him. It was events like that. It was seeing some friends get sick, colleague surgeons. We had a senior surgeon, a famous pediatric neurosurgeon, who died. So it was a sort of a combination of factors. We never felt so frustrated, so unable to, to help people like we did with this disease, and we still are. Though we have tools now, as we all know.
Yeah, you raise a point, because one of my colleagues died as well, and it touches you differently when someone who you work with has died because of a disease. And this is one of the things that I'd put across to people, is when they compare it to flu. I said, trust me, none of my colleagues has ever died of flu working in the environment. This was different,
For sure. I think that you've heard that from everybody, from nurses in the field, from respiratory therapists, from anybody who's had the unpleasure of treating these people.
Mm-hmm. Yeah, so that's important. So when you then went through college and you obviously got into medicine, what made you go into surgery? Were you always dreaming of being a surgeon?
No, actually, and I think I had some tacit pressure from my father, who was a medical doctor, to stay in the medical field. He never said so, but I said that there was this bias against surgeons being, like what you just said at the beginning, not particularly knowledgeable, and more sort of a plumber type person. It was I guess my interactions in medical school during my surgical rotation.
Yeah.
And the feeling that I wanted to control what happened to the patients.
Mm-hmm.
As a medical doctor, you're very smart. You come up with this differential diagnoses. You figure out what's wrong with a patient, and then you give them some pills and you hope they take them. As a surgeon, you actually enact cure. So with your skills and your knowledge, you're able to cure people from their diseases. Yeah. And you think about cancer, there's very few cancer you cure with medicine.
Yeah.
Most of them are with a knife.
Yeah, quite true. But I'm just going to say, in defense of the physicians, is that my feeling, based on observing all of the work that you've done, is that I have a feeling, Danny, that you actually really want to be a physician. It's not too late,
I've never let being a surgeon get in the way of being a doctor.
Yeah, absolutely. So what drove you towards cardiothoracic surgery? Because for many people who don't understand, there are many different branches of surgery. Yeah, what was it about cardiothoracics?
Yeah, so people who don't understand the American system necessarily. So you do 4 years of college, then you do 4 years of medical school. And towards the end of the third year, you have to decide sort of where you want to go. And that's sometimes a difficult decision, because the first 2 years of medicine, you don't touch a patient. And only 1 year experience in medical school, you just have to decide what you want to do for the rest of your life. And it's very abrupt, and it might be very influenced by factors that are not necessarily your own needs and desires. So, for example, you rotate through OBGYN, and you have a terrific mentor. And you say, OBGYN is for me, right? That's sort of how you make decisions.
Yeah.
And sort of, you make a decision, then you go into this match system where let's say you wanted to go into surgery, and you put in a envelope, so to speak, a list of the rank from 1st to 20th. Where would you like to train for surgery? Surgery is a 5-year training, general surgery. Yeah. And one day everybody gets together in a room, and you get an envelope, and you run and you hide in a corner, and you open it, and you find where you're going to spend the rest of your the next 5 years in your life. And so that's how it happened. Now, so that's general surgery. You can finish those 5 years of general surgery and just become a general surgeon, meaning you do appendectomies and gallbladder surgery and stomach surgery and intestinal surgery and breast surgery, etc. Or you can continue to specialize. Yeah. So during my second year of general surgery, I was at Columbia Presbyterian in New York. I spent a rotation at the cardiac surgical ICU unit. And at those times, we didn't have critical care doctors running the units. It was you and an anesthesiologist. So this is a very funny story. The anesthesiologist who was there was the wife of the chair of cardiothoracic surgery. And her and I got along incredibly well. And she thought I was, the best thing that's rotated through that unit in a long time. And she compared me to Mehmet Oz. I'm sure everybody in the audience know who Mehmet Oz is. So Mehmet was one of my mentors at Columbia. And one day, as I was finishing the rotation, I always said, you know what, Dr. Delphin, I really don't want to be a cardiac surgeon. I want to be a surgical oncologist. I want to do big liver surgery. That's what I really do. And she goes, no, you're going to be a heart surgeon just like Mehmet. You're going to be a heart surgeon. So I'll say, well, whatever. So one day, the chairman, her husband, comes into the ICU to see a patient. He says, Danny, I want you to be in my case tomorrow. And I looked at him. What do you mean in your case? I'm a second-year resident. She goes, I want you to be in my case tomorrow. Okay. So next morning, I show up to his case, and the cardiothoracic fellow is there with me, and he lets me open the chest. Now, this is a big deal for a second-year general surgery resident who's maybe doing an appendectomy.
Yeah.
So the chest is open. There's a young woman that we're going to fix a hole in the heart. And he goes, great, see you later. I go, great, thank you. So I stepped out of the table. He goes, no, you stay. I'm leaving. So he leaves, and the chairman, Dr. Rose, comes in and takes me through the entire operation. I put every stitch in the case. So this was clearly something that was planned between them.
Yeah.
In an effort to sort of get me to
So they determined that you were going to be a cardiothoracic surgeon.
And they were right. That event changed my life. That single event. And it's amazing how things that happen to you in life like that, they just steer you in a different direction. And so here I am, 22 years later.
And so therefore, where is your passion in cardiothoracics?
You tend to be attracted to what was good in your hospital.
Mm-hmm.
So Columbia was known for the management of end-stage heart failure. So people's hearts just give out. Their ejection fractions are less than 20%. They can't take 2 steps. They can't go to the bathroom. They can't lie flat because they're so short of breath. Their organs start failing. And for those people, usually there's 1 or 2 options. Heart transplant is sort of the gold standard, and artificial heart technology. And my sort of love and my niche has been that. I do all kinds of things in heart surgery, but that's been sort of the thing that's I'm sort of known for.
Yeah. And so you do mechanical devices for heart failure, don't you?
That's correct.
Now, I know very little about this area. Yeah. It's not something that I would come across. I mean, so what does it involve?
So basically, as you happen to ask, I thought I'd show the audience what these things look like.
Wow.
And this is what we call an LVAD, or left ventricular assist device. And basically, as the name suggests, it takes over the function of your failing left ventricle. Right? We have a right ventricle and a left ventricle. The left ventricle is the one that's the more important one because it pumps blood to the aorta and to the rest of the body. And when it fails, blood sort of backs up into your lungs and you get short of breath. So this device basically is connected to the left ventricle and to the aorta. I don't know if I can do this or not, but sort of the tip of the left ventricle is here. We open the chest. Then we insert this into the left ventricle, connect that to the aorta. Now, everything you see in both of my hands is inside of the patient, much like a pacemaker or a defibrillator would be. And they don't hear it, they don't feel it, they don't see it, nobody knows it's there. But this machine, this pump here, it's called a centrifugal pump. This is called a HeartMate 3 device. This here is a centrifugal pump that spins at about 5,000 times per minute and sucks the blood out of the left ventricle and pumps it into the aorta. That needs a power source. And the power source is this cable called a drive line. And sort of this is the unattractive part of this technology.
Yeah. So where does that come out?
So the cable, the drive line comes out of your abdominal wall, either side, and connects to if you will, a purse where you carry 2 batteries and a little computer that runs the device. And that's how you live. You carry this thing around. You're tethered to this power source at all times. Yeah.
So this technology then, it's not quite equivalent to a heart transplant, so to speak, but it can add significantly to the years that someone could live?
Yes, absolutely. So remember, people who are getting either this or a heart transplant have days or weeks, maybe a few months to live. So these are the only 2 choices they have. Good choices. There are other choices, palliative care, etc. And depending on how old the patient is, what comorbidities they have, how sick they are. Like if they're very sick, you don't have time to wait for a heart, or you haven't finished up the heart transplantation evaluation, then this is what you can offer them right off the shelf.
Yeah.
So yes, a native heart, a God-given heart, is very different than a machine. Obviously, with a native heart, the results are tremendous. You have a median survival of 11 years.
Wow.
That means 50% of people live at least 11 years. but we've had 20, 25, 30-year survivors of a heart transplant. This technology has been around less.
Mm-hmm.
There's been ventricular assist devices for 30 years, but devices like this, small, implantable, not a lot of bad side effects, have been around maybe since the mid-2000s.
And so in terms of how much longer it can add in terms of life, what's the longest somebody has lived with one of these things?
Over 15 years, actually.
Wow, 15 years.
That's pretty remarkable.
Wow. So that's tremendous. So this kind of technology, I guess, is going to grow, and it's going to expand over time. And quite frankly, drifting right towards COVID, any thoughts on the issue of the associated cardiomyopathy that can occur in COVID?
So that's a great question, Philip. There's so much, and my followers know we've posted a lot about the cardiac complications of COVID. We don't see much of cardiomyopathy.
Yeah.
To the point that you need something like this technology I just showed you.
Yeah.
You see more acute injury where the patient leaks troponins and cardiac enzymes. We see arrhythmias fairly frequently, some of them the bad ones, the ventricular arrhythmias. You see heart attacks because, as you know, COVID causes a microscopic vascular thrombosis picture in all the organs, including the heart.
Yeah.
Some of that. We see some whose heart becomes really dysfunctional, but that cardiomyopathy tends to be short-lived.
Yeah.
So sometimes you have to resort to mechanical support, but only for a few days, not something like I just showed you, but something external, like what we call ECMO, or a temporary ventricular assist device.
So then, as we drift into the conversation about COVID, and this is what most people will know you for with regards to the quite insightful research and so on, I think probably one of the most important areas to touch on is the vaccine.
Mm-hmm.
What are your thoughts with where we are with regards to the vaccine?
It's funny. It's happening in a sort of a dual screen, much like you are, and you and I are in a dual screen.
Yeah.
A dual screen moment where we have record infections, record hospitalizations, record deaths, sort of a grim picture. And at the same time, we have a sort of a miracle of medicine occurring at the same time, where in January 11th, the Chinese shared the genome of this new virus. In 3 days, vaccine makers went up to work. And led by Dr. Kariko, who most of you, I have a post about her accomplishments. It's now close to 250,000 views, which tells you something. Devised this technology of mRNA construct as a vaccine, and she was poo-pooed and made fun of and sort of discredited for this crazy idea in her native Hungary. And then when she came to the States, the same thing, until she joined with a investigator in University of Pennsylvania, where she still is, who saw the potential of this technology. And now within 330 days, we have 2 seemingly safe and effective mRNA vaccines that are going into the arms of many people. Yeah.
Now, one of the things that I keep on getting asked is, are we now over? Has it finished now that we've got this vaccine? What is the reality of where we are now and how the vaccine will take us to a potential endpoint, and how long will it take?
Well, number one, these are the 2 first vaccines. There's probably another 45 or so being trialed across the world. So when we talk about vaccines, I don't want people to think these are the only 2 ones. These are the only 2 mRNA-based ones that I've heard about.
Yeah.
Most of them are adenovirus-based, like old other vaccines, or DNA vaccines. So, and probably those will start coming out by the end of January, the initial trial data in terms of safety and efficacy. We are nowhere near the end of this. Because of the speed in which these vaccines had to be developed, that's the name warp speed. A lot of things that you would have liked to have in a trial were not done. And in particular, the question of, does these vaccines prevent transmission and infection? Right, a vaccine can do three things. It can prevent you from getting the infection, or if you get the infection, it prevent you from transmitting it, or it can prevent you from getting sick.
Yeah.
These two vaccines do the latter. They prevent you from getting real sick with COVID-19. We don't know whether they prevent transmission or infection.
That's an important point.
It's very important because it means we can't stop doing what we're supposed to be doing, which is masking and distancing and washing. And that's the single most important message I can transmit. And you hear everybody talking about in public health policy. This is not get a shot, goodbye, let me start hugging everybody I love.
Yeah.
And this is going to have no impact on the 110,000 people that are currently hospitalized in this country, or that are going to be hospitalized in the next few months.
Yeah.
So we're going through probably the darkest period of the epidemic here, at least in Europe, where record deaths, hospitalizations. We're starting to amass a volume of long COVID or long haulers.
Yeah.
Which is another syndrome that's sort of sadly fascinating.
Yeah.
That you don't see with flu and other infections, where these people have persistent symptoms that are really quality of life mitigating.
Yeah, absolutely. And it's an important point, I think, when you mentioned about the capacity of the hospitals. Something that people don't understand is that when you hit the capacity and you don't have bed numbers anymore, that's when mortality can go through the roof. How far away is the US from that point where they're almost overwhelmed in terms of capacity?
Well, we are overwhelmed in places like southwest Texas. The state of California is an absolute disaster with very few ICU beds left. I've tried to look up how many ICU beds there are in the United States. I couldn't find that information.
Yeah.
But in many areas of the country, I think there's maybe 6 states where the numbers are steady or dropping, and the other 44 states are increasing their number of cases. And it's a formula actually.
Yeah.
If you get infected, within 2 weeks you're going to see the hospitalizations, another 2 weeks you see the deaths.
Yeah.
So we can be fairly accurately predicting what's going to happen.
Yeah.
So when you see the number of infections we're having daily, it's very easy to predict what's going to happen a month down the road. That's why you hear Fauci and others be sort of quite accurate now in terms of what we can expect into the holidays. You see all the curves, the Thanksgiving bump. You saw the Memorial Day bump, then you see the Thanksgiving bump, which is drastic.
Yeah.
And I'm fearful what the Christmas, Kwanzaa, Hanukkah bump's going to look like as well.
Yeah, no, that's important. We've got a question here, Daniel. Somebody asked us your opinion on the current, the effectiveness of the C19 early treatment scheme, vitamin D, C, zinc, and ivermectin. Any thoughts?
Yeah, so I had to post some of the Goldstein suggestions, not telling anybody what to do. You always consult your physicians and follow, the guidance of your local environment. And there's no robust, randomized, evidence-based medicine to suggest any of those treatments that are asked by the person who asked. Namely, vitamin C, vitamin D, zinc, and ivermectin. Yeah. The first 3 seem quite innocuous.
Yeah.
And there's very good theoretical basis. I think you've written about it, Philip, as well, on zinc and vitamin D and vitamin C for their particular properties. Zinc has an immune response enhancement properties.
Yeah.
Vitamin C can be an endothelial stabilizer. Vitamin D is also a pro-immune response agent as well. So I don't see any downside, and I suggest that anybody who's diagnosed with it to take it.
Yeah.
Knowing that the downside is basically zilch.
Yeah.
Ivermectin has captured sort of the imagination of a lot of people based on Dr. Corey's, I think, Senate hearing and the FLCCC. Anybody who wants to look that up, flccc.org, I believe.
Yes.
which is a group of mostly critical care individuals who basically reviewed the entire literature on ivermectin. Ivermectin, also listening in, is an anti-parasitic agent. Cost about $3 a pop, so not expensive. It's used around the world, particularly in South America and Africa, where parasites are endemic. And it's found in vitro to have very powerful antiviral properties. The concern I had is those initial studies, in order to mimic the concentration of ivermectin that was seen in vitro, you would have to be popping hundreds of pills a day.
Yeah.
Now, that apparently might or might not be the case. Some randomized clinical trials and a lot of observational, anecdotal, I saw this, I treated my patient and I saved him, data out there. What I haven't seen is a true double-blind is the key, randomized clinical trial in a country with a credible history of academia, put it that way.
Yeah, you come on to a very important point, which is the principle of evidence-based medicine.
Yes.
Now, evidence-based medicine is an essential part of how we practice medicine. Our problem is that it has never been able to work in the context of a pandemic. This is kind of like an unusual circumstance. So where do you sit with regards to, do you wait for all the evidence? Do you treat with what you've got? What is your thought?
I think most people that are not in medicine don't realize that 99% of what we do is not evidence-based. And some people might be frightened at that. But I mean not evidence-based, meaning there's not a randomized clinical trial to answer every question we have in medicine.
Yeah.
As we treat patients every day. That just doesn't exist. Should I give this diuretic or that diuretic? Oh, let me go to the New England Journal and find out if there's a randomized clinical trial comparing Lasix versus spironolactone on a 60-year-old man who's obese. It doesn't exist.
Yeah.
Life is not that way. Randomized clinical trials are extremely expensive to conduct, and they're long usually. So most of what we do in medicine is what we were taught as residents, what experts think is the right thing to do, and it's sort of a compilation of small series, maybe a randomized trial, observations, gestalt, zeitgeist, whatever you want to call it. Always in mind that we're trying to do the best for our patients. And we might be wrong. So a lot of medicine is really art and not quote unquote science. And it's important for the audience to understand that. Why didn't they do that? That's not evidence-based. Well, sorry, we're not going to have evidence-based medicine for everything we'd like to. What do you think? Let me turn that back to you. What do you think?
I'm one of those people who when you're in a pandemic, and as far as I'm concerned, I remember speaking to a doctor, and I said to him is that what I want to feel is that if my patients die, I have done everything in my power to try and keep them alive, okay? And whilst you may not have an evidence-based trial, if you can sit down and you can explain the principle of what you're doing, why you're doing it, there may be some evidence for the value of it. In some senses, I believe that it is better to try something than to sit and watch a patient die, because this is essentially what happens. So when we think of ivermectin, I probably am in the group that I don't know. I can't say that I can imagine that it's a wonder drug, but if it shows that it has some efficacy, and you've got patients who are dying, and you haven't got any other options, and it's a bit more complicated because we have things like doxycycline and azithromycin around. So the question is ivermectin better than what we've got? That's a different question. But initially, when you don't have anything, what do? Do you just say I have to wait the 6 months or the year and the patients are dying? It's a tough one. It's not easy because it's not how we normally practice medicine.
Yeah, well, fortunately, the landscape is changing, and those who follow my posts know that we made remarkable progress. Forget about the vaccines. We now know steroids help a
Yeah.
subset of patients who require oxygen or non-breathing, non-mechanical ventilation. We now have antibody cocktails, like Regeneron and the Eli Lilly product, that are very good at reducing viral load and presumably reducing the chance of getting infected and hospitalized in the outpatient setting.
Yeah.
We have all these other adjunctives that we think might help, the vitamins and the zinc, so forth. And sure, ivermectin is something that perhaps should be considered. Now, most of the trial and that document that the FLCC put together is not been peer reviewed.
Yeah.
It's lying sort of dormant in preprint servers.
Yeah.
That's one of my sort of skepticism about just endorsing these so openly as they have, and they call it a wonder drug, which I think is a bit irresponsible.
Yeah.
There are some side effects, particularly taking warfarin, that could be a problem, and a lot of people take warfarin. So, more to learn. We've gotten very good at other things. We know we don't admit people to the hospital like we used to, and we know how to help them at home with a oxygen saturation monitor.
Yeah.
Remember, when you put people in the hospital, they can get sick from being in the hospital.
Yeah.
There's bugs. There are drug-resistant bugs that you can acquire. You can get clots in your legs. And there's morbidity of being in the hospital. So by keeping people at home as much as we can, that I think is helping. The other thing that's happening in the pandemic is that the demographic being admitted is different. We're seeing more younger patients being admitted because they're the ones that are more sort of laissez-faire.
Yes.
Getting infected. Some of them becoming symptomatic. But their chances of survival are better even when they get admitted. And the very sick nursing home residents, we've learned our lesson, and we're protecting them in the nursing homes and long-term care facilities. So the demographic is a bit different. It's interesting, why is Africa not seeing a lot of patients? That's an interesting thing. I always wondered why. And the sort of the word out there, so to speak, is that the median age in Africa is 19.
Absolutely, yes. So they're younger.
They're younger, and it's nice warm weather.
Yeah. So here is a question that I threw out recently when I was speaking with someone else. And I asked them the question, I'm asking you the same question. What is plan B if, for whatever reason, the vaccines don't do what we hope that they're going to do?
Good question. We failed, at least in this country, to address the virus as you would in any other pandemic, with distancing and washing and masking. Both at the administrative level, in terms of instituting a war against this thing, and public behavior. There's still a good chunk of the population who does not believe this virus exists. This 99.5% of people survive. That there's no other consequences to the virus. That long haulers don't exist. That the hospitals are being taxed. We're putting our hospital system in ruin financially. Hospitals are losing billions of dollars. So all these consequences about something that a lot of people don't think exist. The mask has become a political flag. Why? Is putting a seatbelt on or a helmet when you put a bicycle, you're gonna get on a bike, any much different than this? No.
That's right.
You do it because it makes sense. It might help you and others. Just do it. And so, I and many others have gotten a lot of pushback over that. Where's the evidence base? Well, we can't get evidence based on masking. That's important. There's a lot of epidemiological data that suggests that they work. And even if they work a little bit, you might be helping a lot of people if it just works a little bit. Maybe you decrease the viral load in your nose enough that if you're infected, you're not going to get sick.
So then it raises again one of those other issues that I guess I see a lot of for the counter view, so to speak, to what we're doing. And the counter view is that lockdowns have an effect and they are damaging in their own right. There is financial damage. This is why I asked the question about the plan B, because what do we do if we don't have a way forward? Do we accept it?
Well, clearly we can't accept it. And I think if the vaccines don't work, although every point shows that they will work.
Yeah.
To one extent or another, where they prevent transmission, infection, we don't know, but they prevent people from getting sick and getting to the hospital. That's good.
Yes.
And the therapeutics will continue to progress.
Yes.
So I think we'll have better understanding, and you've been one of the leaders in this, and the whole idea of autoimmunity and understanding, the pathophysiology of this disease, how it affects us. But we have better anti-inflammatory agents or better ways of using the ones we, repurpose drugs. We'll have better antiviral cocktails. And sadly, we will continue to improve the exposure of the community. There's going to be more people going to get infected and asymptomatic and add to the herd immunity idea. So the more the community will have been exposed over time. Again, that's not the way. Herd immunity has failed miserably. It's failed in Sweden, which is the only country that actually really tried it.
Yes.
So, but yes, if this vaccine happens to not work and none of the other 45 vaccines happen to work, then we're going to continue to pay the price as more of the population gets immune. In combination with therapeutics, that's how we will live. And hopefully, eventually this becomes an endemic and not a pandemic.
Yeah, this is right. It could become in a similar way to what has happened with flu. Flu has almost become endemic, and we have to vaccinate every year against to keep the numbers down. We may see a very similar picture with regards to that. Now, Daniel, as we're coming towards the end of our time, I wanted to touch on a few of the other things that I hadn't touched on before. You are a magician, aren't you?
Well, you were very generous with that term. I did do magic as a teenager. For 4 years, I used to put shows on and so forth and create my own tricks. And I've passed that on to my son, who's a much better, I don't know if he's here or not. He's a much better magician than I am. But yeah, wow. It's sort of, I think the fact that I like to play with my hands, I suggest I'm a magician, I'm a pianist, I'm a surgeon. So I think those things all kind of go together.
Yeah, well, you've mentioned what I've been looking forward to all day is that you are also a classically trained pianist, aren't you?
Again, you're being very generous. That's not quite the case. I did take, probably half of your audience was forced by their parents to take piano lessons. and I feel I've fallen that 50% that got pushed to do so because my father was a pianist as well. So I was forced, and I sort of never enjoyed it from age 6 till age 11. And then I said, enough, I don't want to do this anymore. My two sisters were on the line, probably lasted maybe a few months before quitting. But I think I got enough of the basics of reading and how to move my fingers on the scales and harmony that I was able to pick it up when I went to in college. And I sort of started playing again, and sort of mostly the music my mother liked to hear. Mom, if you're on the line, hi. So sort of the music of the 50s and 60s, and then I, more of the contemporary stuff. So I cannot play classical music now. I'm not that good. I don't have the time to invest in it. I do, the Billy Joel and the Elton John kind of thing. So that I like, and that's sort of what I play when I have a chance.
So would we be pushing it too hard, Daniel? If I said to you, myself and maybe quite a few of the viewers would love to hear you play a tune. Is there anything that you would do for us?
That was not part of this.
I'm sure you can play a tune for us.
I could.
We'd love to hear it.
Oh boy. But before I do that, I must turn to, if one looks at your profile, one sees something that says dementia research.
Yeah.
We're all pretty crazy right now with this pandemic, so I think it's very appropriate. But how do you go from dementia research to autoimmunity ideas behind the COVID pathophysiology. That would be a fascinating topic as well. Maybe I should be running this.
Yeah, well. To be quite frank, I've been doing dementia research for over 10 years, and so when the COVID pandemic hit, I was using the principles that I had been using with dementia, which is that what you see in front of you is very rarely the pathophysiology. I tend to use type 1 diabetes as the example. You see glucose in the urine, that's not the disease. You see elevated glucose in the bloodstream, that's still not the disease. You see low levels of insulin, that's still not the disease. The disease is in the beta cells of the pancreas. And so it's about 4 steps away from the obvious symptoms. And so I applied a very, very simple principle with regards to getting to COVID, and just reflected on the groups that were primarily affected. I thought hypertension being a significant risk factor was in truth very, very strange. And this is what drove me to hit serum ACE. And once I hit serum ACE, it was a matter of time. And then the thought of autoimmunity came. Still trying to demonstrate that to many people. Most people still don't quite believe it, but it's a work in progress. There still needs to be a lot of research done.
Yeah. Anybody in the audience interested in asking a question?
Well, I think at the moment what they're very interested in is that they want to hear you play the piano.
That's embarrassing. That's embarrassing. All right.
Yeah, come on, give us a tune.
That'll be one of my mom's favorite songs, I guess.
Yeah. So for all those listening, this is a moment that we've been hoping for. Could we get Danny to play a tune for us?
Oh, boy.
And this is for Mom, isn't it?
It's for Mom. Mom, if you're there.
Wow, well done. Excellent. Wow. Thank you so much for that. That's wonderful, Danny. Yes, you are quite a talented person in multiple different skills and so on. It's tremendous. I think it was a great honor. And I'm just highlighting this for those who weren't quite sure. He was the top voice on LinkedIn in the Frontline Health this year. Incredible, because I'm sure that you weren't particularly doing much on LinkedIn before this. You've just done an incredible job over the past year.
Thank you so much. It was a great pleasure to be here with you. And thank you who watched.
Excellent. And thank you very much for everyone who is here with us. Thank you again, Danny. I'm sure we can speak again in the future to hear an update on what's happening.